Thank you very much for the invitation to speak at the BGIICC meeting for 2021. I know we are all facing challenges, and the good news is that we can meet virtually at least, and I look forward to the day I can see you all in person again. So I'm going to be speaking about missed breast cancer, the role of unconscious bias in breast imaging. These are my disclosures, and I will talk to start with about the importance of medical errors. These are the third leading cause of death in the United States and likely around the world. They're a substantial cause of morbidity and mortality. And errors from missed breast cancers are the most prevalent condition that result in medical malpractice amongst all physicians in the United States. Missed breast cancers, where we see them in retrospect, and interval cancers found within 12 months of a normal screening mammogram occur at fairly high rates of within 1 to 35% of all cancers. It's very important to understand the cognitive, the way we think, the biases during mammographic interpretation that helps improve awareness of unconscious biases and reduces the rate of missed cancers. So a missed cancer is where the finding is not observed, but we can see it in retrospect. And that is the most common, about 30% of errors. Misinterpretation is less common, only accounting for 2%, where the finding is identified, but there's an error in the interpretation that leads to a diagnostic error. Now, the causes of missed lesions are the bias, technical factors, such as poor positioning, or poor training by the technologists, and then patient factors like breast tissue density that I'll be speaking about in the second talk. So if we think about biases, it's very important to understand decision making in terms of two types of thinking. Type 1 thinking uses a very intuitive, subconscious, and quick thinking where less than 1% is of conscious thought. And this is actually a very useful kind of thinking. It makes us very quick, but it makes us prone to bias. Type 2 thinking is more slow, deliberate, analytical, and effortful, and it's quite often used when we're challenged with a difficult case. And we often don't like to use this kind of thinking, and we kind of put those cases at the bottom of the pile when we were dealing with films, or we put it to the end to allow ourselves to think about it because it takes a lot more effort. But it's more likely than the type 1 thinking to get to the right diagnosis. And this has been well described by Tversky and Kahneman. Kahneman actually won the Nobel Prize for Economics based on this kind of analytical thought. Now, if you think about a radiologist who's going through hundreds of cases during the day, you want them to be fast and efficient. And this kind of radiologist, this kind of habit is usually going to rely on type 1 thinking to really get through the volume. On the other hand, when you have a radiology resident who's just starting their training, they don't have the experience, they're going to need to use a lot more effort to come to the right diagnosis. And it might take them 45 minutes to get to the right diagnosis that the first radiologist with type 1 thinking might reach in a couple of minutes. Now, complex decision-making uses both type 1 and type 2 thinking. And so it's important to remember that they're both valuable, and yet, when we use type 1 thinking, we are much more susceptible to bias. And so that's what we have to remember, to try and remember not only to use just type 1 thinking. So what are the most common biases in breast imaging? There are 7 that I'm going to go through, and then I'm going to talk about some of the most commonly missed or misinterpreted lesions. So this is a case that was in the screening mammogram pile read by one of the radiologists who looked at it and saw the 2 clips, one on each side, from a previous MR biopsy on the right and an ultrasound biopsy on the left. And when they saw this, they said, oh, it's just from prior biopsy change. But even when they compared to the images from the prior 2-year screening on the right, there was a clear change, but this was disregarded by the radiologists because they just assumed this was post-biopsy change. So even when faced with the evidence of a change, they were fixed on they'd already made up their mind that this was post-biopsy change. And this delayed the diagnosis, where the patient presented a few months later with axillary lymphadenopathy, and ultrasound showed a mass at the site of the prior biopsy. And this led to a diagnosis of a 4.6 centimeter mass, which at this point had lymph node and bone metastases. This is another example of a woman, 28 years old, with a right nipple piercing, presented with inflammatory change and a discharge from the nipple 1 month after the nipple piercing. And she presented after a 2-week course of antibiotics. So looking at this, the radiologist made up their mind, this must be infection. And they did not do anything further. The patient presented 3 months later with a follow-up ultrasound, and this time the mass was identified correctly as having progressed and had markedly deteriorated, this time with axillary lymph node metastases. And on MR, you can see that the entire right breast was filled with tumor. And this was an invasive ductal carcinoma with an 11 centimeter tumor at this point, with lymph node, bone, liver, and lung metastases. So the radiologist had decided at the time of presentation that this was infection, despite other evidence to the contrary. And this is what we call the anchoring bias, where we fail to adjust an initial impression despite receiving additional information. And so this can be avoided if you don't formulate a diagnosis until you've got all the data. Try and disprove your initial diagnosis, like, could I be wrong? And if the symptoms progress or don't fit the diagnosis and there's something a bit off, it's very, very useful to get a second opinion. Just getting another set of eyes on this can really help. So asking yourself, what else could this be, or what have I forgotten to consider, engages the type 2 thinking of your brain and helps you to avoid making that error. Now, here's another example, very common in breast imaging. So this is a patient with a fatty breast and a mass, and the ultrasound done by the technologist found a cyst in the breast. And so the first thought, especially if you're going very quickly, is, I have a correlate, that's perfect. But you want to think, what else could it be? Could there be something else? And in fact, when the radiologists went in, they could see that there was a second mass that was a much better correlate, that was at the right distance from the nipple, 4 centimeters as opposed to 3 centimeters, and deeper in the breast as compared to the more superficial cyst. And this permitted a diagnosis that was an invasive ductal carcinoma. So finding one abnormality is not where you stop. You want to keep going and look for something else. Here is another example of a patient who had a palpable mass in the left breast. This was identified, you can see by the circle, and they did an ultrasound, and you can see that there is clearly a mass at that area. And this turned out to be an invasive ductal carcinoma. The radiologist stopped at that point, however, and did not look at the rest of the breast. And this is what we call the satisfaction of search bias, where we stop at the one abnormality. And in fact, when a review by a second radiologist was done, they identified a second mass in the right breast contralaterally that had developed in the previous 3 years. And this led to a diagnosis of a high-grade invasive ductal carcinoma that was in fact larger than the initial mass. So you really want to avoid this kind of error. Here's another example of a patient with one abnormality found. This was correctly identified. It was localized, and this was a invasive ductal cancer. But in fact, when a radiologist reviewed the case after the localization, there was a second area that was missed on the initial assessment. And this was shown by MRI and then subsequently proven to be another focus of carcinoma. And this, in fact, was a lobular carcinoma. So the patient had invasive ductal and invasive lobular in the same breast, 2 abnormalities. And here is a fourth case of another lesion showing a mass that persists. And when we looked with tomosynthesis, there was, in fact, additional tumor. So we know that on ultrasound that and on mammography, we can often see additional sites of tumor. And so when we have an abnormality, we must avoid dissatisfaction of search. So how do we avoid this bias? We want to make sure that we look systematically, use a checklist approach, use a secondary search after the primary search has been done, and think about related diagnoses and common diagnostic combinations. So it's really important to remember that we know that many cancers, 40% may be multifocal or multicentric. So look for additional abnormalities when we diagnose a cancer. And try and avoid formulating an impression, especially if you, until you've looked, did I look at all the other areas? And was the lesion that I saw on ultrasound the same as I saw in mammography? And what would I think about the diagnosis if I interpreted the prior study myself and hadn't read the prior impression? Now, here is another example of another bias, and this is, again, something that we do very commonly. This is a patient who presented with a large mass in the left breast. It was palpable. It was shown to be a very large tumor occupying most of her left breast. And when we looked at the mammograms, you could see that there are these calcifications in the breast. Very suspicious. And so the first thing we think about is, well, did she have it on prior screens? So we looked back, and 2 years earlier, there was in fact another cluster of microcalcifications right at that site. And we're like, the instinct that we all have is, oh my God, did I miss this? And then if it wasn't me, how could that radiologist have missed it? And that's our judgment is what we should really avoid. This is the hindsight bias, where the abnormality that we see is much more obvious in retrospect. So how do we avoid that? Is we want to avoid from underestimating the difficulty that we would have had when we first made the initial diagnosis. And the reason why it's important to avoid that is because it's the best way to learn from mistakes. And understanding, accepting, and forgiving these errors is really an important component to avoiding these cognitive biases. So instead of saying, how could they have missed that, say to err is human. We're all human, we all make mistakes, and the key is to try and learn from them. Now, here's another patient who has very low density breasts, and on first look, it's very normal. However, an astute radiologist correctly identified this abnormality right at the edge of the film in the left IMF. This is an area that's often easily missed. And on ultrasound, this was a cancer, which was luckily T1C, already had one node, but no metastases. So this is an area that can be easily missed. And here is another patient who was not so fortunate. So this was the mammogram in 2012, and the mammograms were read as normal. And in 2017, 5 years later, there was a marked progression on the left breast with new axillary lymphadenopathy, retraction of the nipple. And you can see that in retrospect, there was retraction of the nipple on the left. And this was a new finding. It was not commented on by the radiologist or the technologist, but clearly asymmetric. And this is an area that really should be identified as abnormal, because this area is very lymphovascular and can lead to early progression to lymph node metastases. So this blind area is one to avoid. And this unfortunately led to a late stage diagnosis with stage 4 disease. So this is what we call the inattention bias. So it's like the blind spots. And how do we avoid that? Well, we want to make sure we avoid this tunnel vision, step back, look, and check all the blind spots. Be aware of what the blind spots are. And when we look on the craniocaudal view, the no man's land, the retroglandular area behind the tissue, the glandular tissue on the craniocaudal view, is an important area to look at. And a third of lesions are missed that are located here. The medial aspect on the CC is often replaced by fat and sometimes a blind area, and we should really pay attention to that. Anything along the junction of the fat glandular area is an important area to evaluate. And all fat glandular borders are very important, as they may be the only way to pick up a cancer. The retroareolar location, as I mentioned, is a very important blind spot, and we should always check that before we sign off the case. Always ask yourself, did I remember to check my blind spots? What about on the MLO view, the retroareolar location as well? We also have Tabar's Milky Way behind the pectoralis, or behind the glandular area and in front of the pectoralis, as a very important spot. We often see lymph nodes, but we have to double check to make sure there's no lesion. And in fact, that was a lymph node that was suspicious and was a cancer. The inframammary fold, as I mentioned earlier, is an important area to check. It's difficult to compress correctly, and the technologist may miss this compression. That's a very important blind spot. Look at it carefully, and here, in fact, you can see right at the edge, like in that other case, a small cancer that was actually correctly identified. So step back, look at the big picture, and always check your blind spots. Okay, how are some other cases? Here is a case, a screening mammogram. This is a focal asymmetry. We see it. And in fact, we saw it on the prior study quite a few years earlier. So the radiologist identified it, but interpreted as stable. 1 year later, the patient presented for right focal breast pain. The mammogram was again evaluated and called stable, but they underwent a targeted right breast ultrasound. And on ultrasound, there was a small invasive ductal cancer, 1.5 centimeters, low grade, which was identified. And when the clip was placed, it correlated exactly with this, asymmetry, focal asymmetry. So beware of this kind of slow growing or slow change, and try not to be dissuaded by the prior report. So if you see an abnormality that you think is concerning, you really want to investigate it, even if the radiologist reported it as normal on the prior case. And this is where getting a second opinion can be really helpful. Get another set of eyes. If you were looking at this case without any priors, would you be concerned about it? And ask yourself, what would I think the diagnosis was if I had interpreted the prior study myself and had not read the prior impression? So those are some of the common biases that we see, and we're all susceptible to them. So engaging that part of type 2 thinking is really helpful. Now, what are some of the most commonly missed cancers? So the cancers that don't look like cancers are the ones that we often miss. So those are the ones that look stable or pseudo-stable. The benign appearing masses, the high-grade tumors, the triple negatives, and the BRCA gene mutation carriers. The cancers that are seen on only one view, and those that are the developing asymmetries, for example, the invasive lobular carcinoma. So how do you avoid? So double reading has been shown to be very useful, and there's a lot of evidence that artificial intelligence is now going to potentially be an effective second reader. But whenever possible, you can consult colleagues on challenging cases, getting good training. So even attending this conference, the BGICC conference, will show you that you can actually find up to 50% more breast cancers. So that's a really good thing. So let's look at some cases. This is an example of a woman who had been screened every 2 years for a long period of time. And you can see that there was a mass in her lower medial right breast that very, very subtly changed over time. And the radiologist in 2017 decided to recall it because the margins looked a little bit less clear. And the ultrasound showed that there was a mass. And in fact, this was a 3.7 centimeter invasive ductal carcinoma. So it was relatively stable, but slowly grew over time. And looking at the prior 7 years earlier was really helpful to show that clear change. Here is another example of a very subtle focal asymmetry that really changed very slowly and is difficult. But if you compare back to 7 years earlier, perhaps there was a slow progression, and that's what made the radiologist decide to call it back. And this turned out to be a 1.3 centimeter grade 2 to 3 invasive ductal carcinoma with one lymph node. So be careful of these pseudo-stable cancers. Review the prior mammograms and go back at least 5 to 7 years of comparison mammograms. Don't just rely on the most recent prior mammogram. Now, here's an example of a different kind of case where we see a new mass in 2014 indicated by the arrows. And the patient underwent an ultrasound. And the ultrasound was done with not very good quality. You can see that the lesion is really not well delineated or magnified, and we don't see the internal architecture at all. It was called a cyst, even though there's no enhanced through transmission. The patient came back and 6 months later with a palpable mass. And the radiologist and technologist at this point again saw this lesion and called it an enlarging cyst, even though it does not meet all the criteria of a cyst. It's not well marginated, there's no enhanced through transmission. And finally, another assessment 2 months later showed with proper gain settings that this was a solid mass, and this turned out to be a high-grade invasive ductal carcinoma. So be very careful of the high-grade tumors. They can simulate cysts, especially when the proper settings are not used. And you really want to make sure that you have all the criteria of a simple cyst before you call it well circumscribed with enhancing through transmission and anechoic. Now, here's another example of a case with a mass in the right breast. An ultrasound was done, and this demonstrates a fairly well circumscribed mass with enhanced through transmission. This was called a BI-RADS 3. And 6 months later, the patient returned with a marked increase in size of this mass. And this turned out to be another high-grade invasive ductal carcinoma. This now was 3.4 centimeters. So high-grade tumors can really simulate benign lesions like fibroadenomas. And so we have to have a high level of suspicion when we look at this tumor, make sure the margins are really well shown for all of this. And in fact, perhaps this might have indicated that it wasn't completely well marginated. And putting on the color flow can definitely help. And letting the patients know if there is any increase in size, they should return sooner than 6 months. It's really important that high-grade tumors be carefully identified and not missed. Here's another patient with a mass that was called probably benign. And you can see that it has several features of benign lesion, but it's quite heterogeneous, which could raise the question of really is not necessarily a BI-RADS 3. And this turned out to be a invasive mucinous carcinoma with the characteristic high T2 signal intensity with an enhancing mass. You can see it's quite heterogeneous in its internal echogenicity, and this is a reflection of much of the mucin content. So benign appearing masses occur. They occur most commonly with high-grade tumors and triple negative tumors, and especially in the patients who are BRCA gene mutation carriers. They can often simulate benign masses with enhanced through transmission, and they can look like either cysts or fibroadenomas. So really view these with a high level of suspicion, particularly if you're dealing with a high-risk patient. Anything rounded should really prompt you to investigate with a biopsy. And you really have to have all the features of a benign lesion if you're going to call it a BI-RADS 3. Now, what about this case? This is a woman with heterogeneously dense breast tissue. There is a prior mammogram, and this showed a focal area in the in the left breast. And this is what happened after and even 2 years after. And this area in the left breast was identified as a single view asymmetry, but was dismissed as being unremarkable because it was only a single view finding. And it took 2 more years before the diagnosis of cancer was established. This time it was with 3 lymph nodes involved, and this was an invasive lobular carcinoma. So focal single view asymmetries can occur, especially if you see it on the CC view where the compression is more uh, able to be performed. Pay attention to those single view asymmetries. So although we know that it's a low rate of malignancy, we should really be careful to investigate it further. Now, here is another example of a patient with a very stable focal asymmetry in the right breast at 3 o'clock. And over many years, it was stable. And finally, the patient was called back for some coarse heterogeneous microcalcifications, which was adjacent to this focal asymmetry. And then it was investigated. It was worked up with spot compression and tomosynthesis views. And the pathology biopsy was requested for the calcifications, which showed a fibroadenoma. And the mass was shown, and I'll just show you the tomosynthesis to show you that this clearly had some architectural distortion, and this what turned out to be a small invasive ductal carcinoma. So a relatively stable mass that was accurately identified on the diagnostic mammogram and tomosynthesis. This is another example of a patient with a developing asymmetry in the upper outer quadrant. And you can see that over the few years from the first mammograms on your right in 2009 to 2013, there was a slowly developing asymmetry. And this became more conspicuous and was accurately recalled. And this was proven to be an invasive ductal cancer. So a developing asymmetry is something that you really need, again, to go back 5 to 7 years to look at the comparison mammograms. Don't just rely on the most recent prior mammogram, because that is the way that you're going to really make an accurate diagnosis. And then this case is another example of the most difficult cancer that we identify. And this was a patient who presented with a left discomfort and possible lump. The mammogram was done, the tomosynthesis was done, and ultrasound were all done and reported as normal. But because there was some skin dimpling, and the palpable abnormality was still suspicious, an MRI was suggested as a problem-solving tool. And what we see on the MRI is the extensive tumor that is involving the entire left breast. And even in retrospect, going back to the tomosynthesis and the mammogram and the ultrasound, this is a completely normal conventional imaging, and the MRI is integral to making the diagnosis. So this turns out to be an invasive lobular carcinoma, which is the most difficult cancer that we can diagnose. So it grows in single file. It often fails to elicit a desmoplastic reaction and can be very challenging to detect on mammography, ultrasound, and even MRI. And I've had a few cases, as I'm sure some of you have, where even in retrospect, the MRI is normal. So it's one of the humbling cases that we want to really be careful to diagnose when at all possible, and use all of our tools, including physical exam, if we really are suspicious. And often I will rely on MRI to help with that diagnosis. So we've talked about the common biases use that type 2 thinking and ask yourself a question before you sign off the case is really a great way to help avoid some of these biases. Be aware of some of the most commonly missed or misinterpreted lesions, the stable single view, benign appearing, and developing asymmetries. And so I'll leave you with this quote, which I think is really useful, from Albert Einstein: ego equals 1 over knowledge. The more the knowledge, the lesser the ego. The lesser the knowledge, the more the ego. Thank you very much, and enjoy the conference. Thanks again.